হ্যালো, কে কার? Should we start?
Yeah. So, very good evening to one and all, and warm welcome. We have gathered here for an academic feast that is to follow on this very special Teachers' Day. As we all know, India has one of the highest burden of cardiovascular diseases. Indians tend to have clustering of cardiovascular risk factors and develop CVD a decade earlier than Western countries. ESC Congress 2024 was held recently, and many interesting updates and guidelines have been released. To discuss some of the findings and to understand how it can translate to Indian clinical practice, we have eminent teachers with us, and I have the honor of introducing them. For the first talk on advances in CVD management and therapeutics, we have Dr. Soumitra Ray sir as our esteemed speaker. Sir is consultant cardiologist at Woodlands Hospital, Kolkata, visiting consultant at Manipal Hospital, Kolkata, has served as ex-vice president in Cardiology Society of India, and has published numerous papers in both reputed national and international journals. We warmly welcome Dr. Ray sir. For the second talk on innovations and challenges in heart failure and cardiovascular disease, we have Dr. Uday Jadhav sir as our esteemed speaker. Sir is consultant cardiologist and honorary professor at MGM Hospital in Navi Mumbai. Sir has significantly contributed in the field of clinical research and clinical trial by being a principal investigator, and is also vice president of HFAI. We warmly welcome Dr. Jadhav sir. And now I hand over the podium to our first speaker, Dr. Soumitra Ray sir, for his talk.
Thank you, Dr. Prajapati. Good evening. And good evening, Team Docomo and all the delegates who have gathered today. Now, let me first share my slides. Are the slides visible?
Yes,
Are
sir.
the slides visible full screen?
Yes, sir.
Okay, thank you. So as Dr. Prajapati gave a nice introduction, the ESC 2024 has just been concluded at London. And it was a good, fruitful meeting. I participated online in most of the major sessions. I was a live audience. There are 4 major guidelines came out this time with chronic coronary syndrome, with blood pressure and hypertension, with atrial fibrillation and peripheral vascular disease, as well as there was a consensus statement on obesity and cardiovascular disease. So all are very important documents, though not above controversy. There are certain points which need more clarification and discussion and argument. But those are very interesting. But this is not a session to discuss about the guidelines which have come. Here in this session, both from my side and Dr. Uday Jadhav's side, I find that most of us, we are talking about the general papers which have been published, which are important and can form some kind of change of our practice in different areas of cardiovascular risk management. Dr. Jadhav will focus mostly on the heart failure aspect, and my subject is mostly on the lipids and different cardiovascular risk factors. So you know that lipid and blood pressure are the major now cardiovascular risk factors. There was a paper presented, very interesting, from India actually, lipid lowering therapy and the unmet needs in patients with angiographically proven CAD from OLA study. Now, angiographically proven CAD means your lipid goals are very well defined. When there is angiographically proved CAD, your LDL must be below 50 or 55, if not 40, if not 30. So those are controversial, but below 50 is not controversial. So what we are getting below 50, achieved LDL below 50, with such high risk population is only 1/4 of population who require their LDL to be below 50. 3 out of 4 are not within range. Only 1 out of 4 has achieved that range. If it becomes 30 milligram, but that is an extreme high risk by Lipid Association of India, and not just any angiographically proven CAD is extreme high risk. So it is very difficult to interpret this data, how many are eligible to have below 30, and of those, how many has achieved. But of course, if your 50 milligram achievement is 25%, you can well imagine below 30 milligram achievement will be very minuscule. Even the 70 milligram, which is a conservative goal, which has been mostly promoted by ACC, but they are now also changing. Even if you take it 70 as a modest approach, then also more than half of the population did not achieve their target. But very surprising, you see that no lipid lowering therapy is only 3%. So 97% of people with proven CAD, they are getting lipids. So no doubt we are giving lipids. We know that lipids are important. We are giving lipid, but somehow we are just giving it in a so-called homeopathic dose. I'm giving a lipid and that's it. And I'm happy. I am not concerned about anything else. It is almost one or none law. Lipid or no lipid. I mean, statin or no statin. So that is very interesting mindset of Indian physicians. And if you see that it is a representative population like diabetes 30%, hypertension around 40%, obesity 40%, smoking 20%. So these are very representative population. And also very interesting, this study, statin prescription, rosuvastatin was 2/3 and atorvastatin was about 1/3. So this is an interesting observation that in India, rosuvastatin is more popular than atorvastatin. Maybe the market pressure, more availability. And also very surprising that high intensity statin was clearly given to 2/3 of patients. So that is a thought-provoking data. High intensity statin was given in a proven coronary artery disease patient. That's absolutely mandatory, and it is given in 2/3 of patient, but you achieve your target in only 25% of patient. That clearly shows that there is itself a difference between high intensity statin, between 20 and 40 rosuvastatin, 40 and 80 atorvastatin, as well as high intensity statin may not be sufficient to achieve our present day goals, and we need to take advantage of the other medicines like ezetimibe and bempedoic acid, whose use was only 1.2%. There makes the difference. PCSK is 0%. So, I mean, it's so minuscule. So that makes the difference. It's not that we are not using statin or not giving statin. So the study concluded that high-risk coronary artery patient, Indian patients, so high-risk status with pressure, sugar, obesity, all in the tune of 40%, which is in the international standard around 20%. In our population, they're all 40%. Over 2/3 of patients were getting high-intensity statin, and almost everybody was getting some statin. But target LDL was only below 25%. So that means that increased and early use of combination therapy, including the high-intensity statin with the non-statin lipid-lowering therapy, is necessary. So that is the clear message coming out. And as I was saying, physicians' disagreement with this treatment. When they're saying that your LDL is 70, but your target is 50, why are you not adding ezetimibe, or why are you not adding bempedoic acid, etc.? 70% of them said that current treatment judgment is appropriate. I think it is appropriate, and I don't care about the guidelines. I disagree with guidelines. So 70% of the 171 physicians who were interviewed told that we don't care about the guidelines. For my patient, 70, 80, 90 LDL is fine. I am happy with the way I am treating. So that's very, very interesting mindset, I would say. We have to perhaps do the psychoanalysis of ourselves. So why we are like this? But that is interesting. So the study concluded, this particular study, that achievement of LDL target was less than 60% of patients at very high risk of ASCVD. Even 70 milligram is not achieved in majority of patients. And primary barrier is physicians' inertia somehow. Then there is another study, a real-world study of remnant cholesterol and ischemic risk after angioplasty. And diabetic, pre-diabetic, and non-diabetic group, they were studied, and it has been found that glucose metabolism is very much related to the remnant cholesterol. We know that if sugar is not controlled, then triglyceride remains high. And if triglyceride remains high, then VLDL, IDL, those kind of remnant cholesterol particle, lipoprotein particles go up in the blood. And that is exactly shown, particularly in diabetic population, and not so much with pre-diabetes, but very much with diabetic. You see the significance was in diabetic group only, 0.045, not in the other groups. So in diabetic patients, we have to be extra careful about remnant cholesterol. And this is a particular population when we should not just look into LDL cholesterol. We should rather look into non-HDL cholesterol. We should look into ApoB. We should look into LPA. We should see all these parameters which can identify the high remnant cholesterol or residual cholesterol. So remnant cholesterol related ischemic risk in coronary patient undergoing angioplasty is amplified in diabetic population. So we should look into it more closely in a diabetic patient and take appropriate action by adjusting the dose of statin and adding non-statin lipid lowering therapy. Again, the emphasis comes on non-statin lipid lowering therapy. Now, another study came that association between lipoprotein particle. Now we know that instead of the milligram per deciliter of cholesterol, it's more important to know the number of particles. Because if it is a small LDL particle, then for say 100 milligram of LDL cholesterol, 100 milligram per DL, if it is a small particle, it will perhaps have 500 particles. And the same cholesterol, if it is large particle, there could be 100 particles. So which is worse situation? The same cholesterol level, 100 milligram per deciliter. But in one hand, there are 500 small particles, and the other hand, there are 100 large particles. And we now know very definitely that the number of particles matters. So the more the number, for the same level of milligram per deciliter cholesterol, it is more atherogenic. That is called small dense cholesterol or small dense LDL, which we are afraid of nowadays. So if you see the third panel, high density lipoprotein, low density lipoprotein, small LDL, large LDL. So small LDL are much, much more atherogenic compared to large LDL. And this is a very funny population. It is not very clear from this slide, but if you see the heading, people living with HIV and people without HIV. This is actually an AIDS cohort. This is actually an AIDS cohort. They have found out the relevance of HIV status on your lipid parameter and on your atherosclerosis. And they have found that people who are HIV positive, they have got more small dense LDL cholesterol. Maybe there is a perpetual inflammation going on. There may be other liver problem going on. Whatever be the mechanism, HIV patients are much more prone to have larger number of LDL particles, which are more atherogenic, and subsequently they have more atherosclerotic cardiovascular disease. So they showed that men without HIV, stronger association between lipid particle concentration and coronary plaque progression. Men with HIV, higher VLDL and lower HDL particle concentration at baseline. So there is some interesting finding. So HIV positive people are more driven to atherosclerosis by intermediate density or HDL or VLDL particles rather than LDL. And rather, normal people without HIV, they are rather more like, as we discussed, that LDL particles are more important. So this is a bit of what we thought will be a different thing, because HIV causes more of inflammation, more of high CRP. So there could be more small dense LDL. But actually in the study, it was shown just the opposite. Just HIV positive people are more driven by VLDL and remnant cholesterol, and without HIV, they are more driven by small dense LDL. So maybe we have to do certain specific program to find out the exact atherogenicity of HIV positive people. But nowadays the importance is going down because HIV is now curable, and majority of people, and the government gives the medicine free of cost. So majority of people are getting rid of their HIV status. So it may not be very relevant long term. This is another very interesting study, which is a bit difficult to understand. I took some time to find out what is happening. Here they are telling that comparison of cardiovascular disease risk assessment tool in primary prevention patient with raised lipoprotein. So there are certain phrases over here. Number one, we are talking about primary prevention, not a known case of atherosclerosis. Number two, we are in the primary prevention group, we are checking the lipoprotein A. And you see in the x-axis, in the abscissa, the lipoprotein is plotted from 50, 100, up to very high, up to 700, 750 of lipoprotein millimole per liter. On the other hand, we are giving the three standard risk assessment tool, Q-risk-3, SCORE-2, and SCORE-2-OP. And you see this Q-risk score is widely fluctuating. 10-year cardiovascular risk is very high when your LPL is 100. It is very low if your LPA is 200. It is very high when your LPL is 350. And it is very low when your LPA is 600. So it doesn't make any sense to anybody. So this is something absurd. Rather, SCORE-2 is a bit more consistent, but then again, it is not reflective of the atherogenicity of LPA. So what found, the conclusion of the study is raised LPA in primary prevention patient has got a wide distribution. Discrepancies in risk assessment tool affect the cardiovascular risk estimation and decision making. Q-risk score 3, we know it is a very good risk score and we really trust it, but here it fails. It fails miserably. This underestimation can result in the undertreatment of patients. Q-risk and life CVD may underestimate lifetime CVD risk, especially with higher LPA level. The degree of LPA elevation affects the accuracy of these tools, and clinician may need to use a range of tools to better suit individual cases and risk assessment. So that makes life more complicated. So one lesson from it, that if the LPA is high, then perhaps the standard risk tools are not very reflective of the exact state of affairs. You rather give the LPA a very high regard and treat these patients as very high risk anyway if the LPA is high. So that is, I think, the best we can conclude and can translate in our practice without getting more confused. Now, we come from lipid to inflammation and compare. So association of inflammation, this is an interesting thing, association of inflammation, triglyceride and LPA with cardiovascular event in the UK Biobank. Now, UK Biobank is a huge thing going on in the world. It's a fantastic thing going on. They are taking the genetic sampling of their normal population, studying them for 10 years, 15 years, 20 years. I just had the chance to review as an expert reviewer of one of these studies. Only yesterday I submitted my review of UK Biobank. They are doing fantastic things. I mean, unbelievable certain things they are doing. Like say, if you think, what is your muscle mass? Whether your hand grip, how strong is your hand grip? Whether that can be translated to atherosclerosis. You see, very fantastic ideas are coming up. And this is such an authentic and huge biobank that I think over next 10 years, we will get many, many interesting and path-breaking, groundbreaking conclusions from this biobank. Now, here, what we are getting here, UK Biobank, 500,000 odd people, I won't say patient, people, without missing data is very high number, almost 440 are having all the data. Missing baseline data for any of, so what are the data they are taking? HSCRP, white cell count, systolic pressure, smoking status, and lipid profile. Almost 440,000 people, we get all the 5 data in full. And here they found that with an HSCRP below 20 milligram per liter, which becomes 2 milligram per deciliter. So we are more accustomed to that, milligram per deciliter. So that is 2 milligram per deciliter, which we'll find more comfortable to deal with. 20 sounds a bit odd. And white cell count below 20,000. Huge number. Most of them are within normal range. I mean, HSCRP below 2 and white cell count below 20, isn't it? That's like a normal person. Then you find they have divided them into 4 groups: high risk, very high risk, lipid lowering, and secondary prevention. And how did they do it? High risk are almost 1/4 of these people, not on lipid lowering therapy. Cholesterol is below 8 millimole. 8 millimole means 8 into 40, around 300. EGFR is good, and no history of diabetes or CVD. Score, they applied the score. Very high risk is somewhere in between, a bit more. Lipid lowering therapy, around 75,000 people on lipid lowering therapy at baseline, but no history of CVD. And about 16,000 of people had infarction or ischemic stroke before the baseline was taken. So a very heterogeneous population, all comer. And of course, many things will come up, but here is a very shortly and briefly what I can tell you. HSCRP is a more robust predictor of cardiovascular event compared to LPA or triglyceride. So that they found with this huge database that of these 3 parameters, HSCRP, LPA, and triglyceride, HSCRP is the most relevant. This applies to both primary as well as those people who have already got cardiovascular disease or heart attack or stroke. Evaluation of HSCRP, LP, and other non-traditional risk factor is needed. We should do this routinely as like lipid profile or blood sugar. These factors may improve cardiovascular risk reclassification. And consider using HSCRP, LP, and other non-traditional risk factors to guide allocation to targeted anti-atherosclerotic therapies. So you see, more and more, the emphasis is coming in the newer world to go beyond the LDL cholesterol, blood pressure, blood sugar, smoking, obesity, the traditional risk factors. Because we have found over decades and decades that even with control of these risk factors and lowering the threshold, still there is a huge residual atherosclerosis. Actually, we are reducing, say we are reducing by 15%. And what is that? Say from 50% to 45%. But 45% remains. So always the submerged portion of risk factors, so residual risk factor, is huge, still huge. We could not touch the chunk of it. We are just playing over the tip of the iceberg. So naturally, people are thinking of what else we can assess and modify to reduce this or to actually touch this sensitive point. Some more information about LPA, which came out this time, that despite LDL being more abundant, LPA is approximately 6-fold more atherogenic than LDA on a per particle basis. And we won't go into pathology because we are talking about the clinical trials, and we know that LPA is one of the residual cholesterol or remnant cholesterol, and it is genetically determined, but we can modify it, though not very effectively at the moment, but there are LPA specific treatment is coming. Another interesting point is that statins usually do not reduce LPA, rather sometimes increase it. Another interesting point is that LPA is more strongly associated with aortic stenosis than coronary artery disease. It is definitely important in coronary artery disease, but coronary artery disease has got so many other risk factors. But aortic stenosis has got hardly any risk factor, and the most important risk factor is high LPA. Patients with elevated LPA levels are at higher risk of adverse cardiovascular outcome, be it heart attack, be it aortic valve stenosis, be it stroke, be it heart failure, peripheral disease, and including all-cause mortality. Elevated LPA can be identified by a routine non-fasted blood test. You don't need fasting, and it can be done in most laboratories now in India. It's very easy, not very expensive. Target patient subgroups. Whom to do it? We recommend that it should be done once for everybody. And it should be done in the first lipid profile that is done in that person's lifetime. On the first sample, you do the LPA. So that is our dictum and that is our mission. But particularly important for those who have got premature coronary disease in the family, or himself had got a heart attack at an early age, or there is by chance known high LPA in the family, etc., etc. Why don't we do it? We don't think about it. That is the most important thing. There are certain practical challenges. Just if you write lipid frosting, lipid profile, it may not be included in the laboratory. You have to write it separately. Insurance may not give it, that it is not part of our policy. And also, it is not yet you know how to handle the value. If you get 30 milligram, 50 milligram, 70 milligram, 110 milligram, what to do? What is the cutoff? Is it 30? Is it 50? Is it 70? Whom to intervene? How to monitor? There are certain issues still not very clear. But we know that it is important, and the more quickly we get the awareness, more quickly we do the tests widely in India, and more quickly we get the appropriate medicine, it is good for the population. So these are the key points. Why test for LPA? Because it's a distinct pathological property, is a family of ApoB, is genetically determined and very much more atherogenic than an LDL particle. The assessment without it is incomplete. Whom should we do it? At least once for everybody, particularly if there is family history or personal history of premature coronary or atherosclerotic disease. Can be done routinely in any blood, non-fasting. It is underutilized, but you have to mention it. And what action? You can improve the risk stratification. Some moderate risk people can go into high risk people, etc. You can optimize the treatment by being more aggressive about the other risk factors, and then you wait for the specific therapy. Now, innovating the clinical management of LDL, if you go back back to LDL, exploring the CETP as therapeutic target. We explored it, we rejected it. Now there is some resurrection of CETP as a target. CETP activity decreases circulating HDL-C level. And we know HDL is important as a scavenger of bad cholesterol. It brings it back to the liver. So CETP curves against HDL. It penetrates the HDL surface. CETP directly transfers the cholesterol ester from HDL to LDL. So CETP is actually bad. It reduces the HDL and it inflates the LDL. We want just the opposite. We want to suck out from the LDL and feed the HDL. But CETP just does the opposite. So we need CETP inhibition. Very simply, because CETP is not our friend, so we need to inhibit CETP. So CETP inhibition decreases LDL and increases HDL. Just keep this simple in your mind. CETP is our enemy. We need to destroy CETP. Now, how to do that? The many trials failed, many drugs failed, and now there are certain new drugs coming up. Low CETP activity has overwhelming evidence for ASCVD manifestation. This relationship based on ApoB, this low CETP activity also associated with lower dementia and less new onset diabetes. So not only in atherosclerosis, but other benefits as well. And CETP inhibition is also investigated as a strategy for prevention of AMD and septicemia-related mortality. So it is just not atherosclerosis. It has got widespread utility in the body. Clinical choice in managing LDL-C, where do novel therapies fit in, and current approaches. We know that now this is a bit controversial. I won't go into it, and there is nothing really new came in the ESC this time. They were not very much active about the LDL guideline this time, so there's no point discussing. Just they were talking about the implementation of the guideline rather. They were saying, look, we are producing guideline every few years with so much of cost and effort. But what is happening in the what is happening in the wide world? They are not taking our advice. Da Vinci studies showed that less than 20% of patients achieved a cholesterol of below 50 or 55. So why this gap between our recommendations and your take-up? So that is a point of concern, but it is on individual basis, individual country, individual society, individual community, individual doctor's practice. We have to all soul search. Just the last bit is beyond lipids. We are coming to advances in thrombosis management, evaluating current and emerging anticoagulation strategies. And this is some old thing recapitulation, global health burden of thrombosis. Thrombosis is responsible for 25% of death worldwide. Stroke people die of stroke. The more the aging population, more the stroke death. Of course, an 80 years man is more likely to die of stroke than a 30-year-old man. So as we are improving the general health, our stroke mortality increases. And it also causing heart attack and venous thromboembolism. Third leading cause of death after MI and stroke. MI and stroke. Since the COVID-19 pandemic, age standardized mortality rate have increased for all the heart attack, stroke, and VT, because we learned that COVID actually promoted thrombosis. That we learned a bit after paying a heavy price. First, we thought it was ARDS, then we thought it was inflammation. But then people realized after 6 months that it is actually thrombosis which is the culprit. And since the anticoagulation treatment started in COVID, the mortality started decreasing very rapidly. So those people who died, unfortunately, at the beginning of the pandemic, when we did not know the pathology. And we know that age-old thing, DOACs versus warfarin, there's no point discussing all these things. Bleeding rate, DOACs and DKA newly diagnosed AF. Garfield AF registry is very old registry. Just they recapitulate in some of the um, clinical practice session, and fact impacting anticoagulation prescribing and adherence. This is interesting. They found out that providers like our prescriber, what we are doing, why we are saying that we are not giving properly the anticoagulation. First point was low A burden or rhythm control. We think that this patient, though is having AF, is not actually needing an anticoagulation because the AF is very short. Now, it is very, very controversial. And this time, the AF guideline came, though it is not very clearly written, but I happened to be a witness of the question answer session. And there's huge controversy of what kind of paroxysmal AF burden you determine that the patient is eligible for lifelong oral anticoagulation. And among the discussants, there was some controversy, but ultimately all of them tried to say that whatever be the burden, whether it is 30 seconds, whether it is 5 minutes, whether it is 4 hours, if there is no contraindication, give oral anticoagulation. So the bias or weightage of all the experts, I found that they were in favor of giving oral anticoagulation. And they were saying that drugs are so safe that you hardly pay a price if you properly give the dose as per the recommendation. And today or tomorrow, you will prevent a stroke, whatever be today's burden of AF. So yes, though, okay, it's an individual decision. We still hesitate to start oral anticoagulation if by a chance Holter monitor I get a 10 beats or 12 beats or 15 beats AF once or twice a day. I don't know whether I should start it or not. I leave it to you, individual decision. But the biasing of the world, or the at least the ESC is going towards giving the treatment rather than withholding the treatment. That much I can tell you. Low perceived stroke risk. Again, we think, okay, even with this, if it's a bit hyped up, stroke is not that high. That is another perception. Patient factor, we think patient is too old, too frail. They is on multiple medicine, on renal failure, etc., taking antiplatelet, and sometimes patient refuse. Very interestingly, what the patient thinks. Patient's number one concern is fear of bleeding. As soon as you explain that it can cause bleeding while you are brushing your teeth or while you are straining at your stool, some people say, no, I don't want this. Then there is some bruising, there is some skin coloration, and some people get very scared, also cosmetically. Also, it is influenced by social media, their friends, their families, their emotional things that I'm taking a dangerous medicine. If I cut my finger, I'll bleed to death, this kind of thing. And also lack of knowledge. What is the chance of stroke? What happens after a stroke? The quality of life, etc. So these are very interesting aspects to discuss theoretically. But how to change those and whether to change those, whether you should change those remain much more bigger questions in the background. And challenges with current anticoagulation therapy, we know that there are underdosing with certain, particularly with apixaban, there is underdosing. Patient perspective, we have already discussed. Strategies to adverse current gaps in thrombosis care. Anticoagulation therapy through the years, why do we need new targets? This background is coming because factor 11A inhibitor is coming. It came 2 years ago, then it went off 1 year ago. Now it is again trying to come back. So factor 11 inhibitor, but I think it is again a negative trial came. Evidence supporting factor 11 as a target by genetic epidemiology and animal studies, and meta-analysis of 2 phase 2 studies comparing factor 11 inhibition with enoxaparin in total knee replacement, and it was a successful trial. But we have to think that It is a promising target for new anticoagulation. Phase 3 trials are needed to establish benefit-risk profile. Factor 11 inhibitors are unlikely to replace DOAC, but may find new indication, like say knee replacement, or may be used in certain high-risk patient when you are scared to give DOAC. But this time came in ESC, a trial which showed factor 11 inhibitor was inferior to apixaban. So again, there is not much of promise at the moment. Coronary thrombus management in patients with acute coronary syndrome, insight from Turkish and Italian Cardiac Society. I don't think these are very relevant in our country, but still we see what they have found out. Impact of high thrombus burden in STEMI with distal embolism, stent thrombosis, no flow, no reflow, slow flow phenomenon. The infarct is big, heart failure is more. So intracoronary thrombus usually occurs with acute plaque rupture or erosion linked to hypercoagulable state, such as thrombophilia, coronary thromboembolism. This is certain new things, but these are rare things. How many people have got thrombophilia and can arise from aortic valve replacement surgery? There are certain stray comments. Tailored management strategies in STEMI, they said there is no ideal management strategy. So that says it all. So you have to tailor made to your infrastructure and to your facilities and need and resources. I mean, nobody can tell you what to do. Each patient requires an individual approach. Consider how the patient presented. Look for culprit lesions, stent implantation. Be careful about stent implantation and more use of intravascular imaging. And lastly, the antiplatelet therapy in ACS and PCI. Again, you know that DAPT, SAPT, de-escalation, escalation, these are now storming any society meeting, any seminar, any conference. But again, sadly, there is no conclusion. Each time there is a different conclusion coming. Trial sequential analysis, TSA, there is a novel way of approaching a problem, suggests that ticagrelor monotherapy, unlike clopidogrel monotherapy, is conclusively associated with improved net adverse clinical event outcome compared to 12 months of DAPT. So just single dose of ticagrelor monotherapy is good. Also, they have shown in another trial that aspirin and clopidogrel are equipotent and equivalent as a single antiplatelet therapy. So that is another thing we can safely use. And I stop over here, giving a bit of a glance of what happened this time in London.
Thank you so much, sir. We are honored to have Dr. Uday Jadhav, sir, with us. We now hand over to Dr. Uday Jadhav for his talk.
I'm Dr. Uday Jadhav, consultant in cardiology at the MGM New Bombay Hospital, and I bring you the innovations and challenges in heart failure and cardiovascular disease from the recently concluded European Society of Cardiology meeting that went on very effectively in London. So let me highlight few aspects which I thought is important. One is the role of biomarkers to guide the treatment of heart failure. Where are we going? We know that NT-proBNP levels are strongly associated with disease severity and outcomes in heart failure across all ranges of the left ventricular ejection fraction. Now, let me say at the outset that we really don't have a guideline which promotes a NT-proBNP or a BNP-directed heart failure therapy. But if you look at the levels of biomarkers, including NT-proBNP in heart failure, and both in HFrEF and in HFpEF, and look at the data from more than 13,000 patients in paradigm heart failure with LVEF of less than 40 and Paragon with a EF more than 45, One thing that becomes very obvious from this slide, if you have the quintiles of the NT-proBNP, that the primary outcomes from the lowest level of the NT-proBNP to the highest level go almost fourfold. The hazard ratio for sacubitril valsartan also reduces to 0.79 and below. What are we trying to say here? That the number needed to treat, if you have a guideline or a BNP-directed therapy for sacubitril valsartan, gets so much better. So the clinical trials actually reflect upon how you are going to treat patients in outpatient practice. So look at the primary outcomes, both for total heart failure hospitalizations, and CV death between enalapril and sacubitril valsartan. Sacubitril valsartan gives you that benefit. So the total heart failure hospitalizations go down, and the total heart failure hospitalizations and cardiovascular deaths also go down. And that's, I guess, a very important highlight if you look at how you correlate NT-proBNP levels. So it's really changed the landscape of what we have been doing over the last 10 years. Where are the future roles? Not just in patients who get hospitalized with acute heart failure, but in the ambulatory patients with a stage B heart failure for early intervention, in acute heart failure, when a decision is required at the time of hospital discharge, and naturally, something that will become a point of guidelines also as to how should we include it. In chronic heart failure, how will you support the GDMT administration? How shall we monitor the patient? Let's say in India, when do you do the NT-proBNP? Is there going to be a regular time frame? Is there going to be a periodic interval based on how patients are clinically doing? Are we going to put a 3 months, 6 months, 9 months, 1 year, or 6 months, or 1 year? Well, all this is a matter of great debate, but should be very interesting. So high NT-proBNP levels, high risk of events. Reduction leads to better clinical outcomes, and that's true for all the therapeutic pillars. And primarily, it has come into focus, more importantly, when sacubitril valsartan got introduced in the therapy of heart failure, along with DAPA and empagliflozin. And the benefits are just irrespective of what is the EF, what are the subgroups, and what are the baseline characteristics. So it's something that we need to keep in mind while treating patients of heart failure. Today, I think it's extremely important to look at the new treatment options and evidences. The ESC London was dominated, I would say, by the presentation of the fine arts heart failure study, to the extent that when Professor Scott Solomon presented it at the ESC, the hall was absolutely packed and there was not even a standing place. So let's talk about it. So this is new from the ESC. I bring you the finest study that has come up. Fine arts is a randomized, double-blind, placebo-controlled trial which tested the hypothesis that we have been waiting for a while. Will MRA, with a new introduction of finerenone, reduce cardiovascular death and worsening heart failure in patients with heart failure in mildly reduced or preserved ejection fraction? The inclusion criteria had an LV of more than 40. Patients were hospitalized, recently hospitalized, or ambulatory. The NPs were elevated. There was a structural heart disease. There were diuretics in the prior 1 month of randomization. Hyperkalemia more than potassium of 5, EGFR less than 25. MRAs 30 days prior were the exclusion criteria. So also naturally were amyloids and peripartum cardiomyopathy. Finerenone was used in the dose of starting at 10 to escalation of 20 or 40. Those patients whose EGFR was less than 60 were given 20. those patients whose EGFR was more than 60 regular, 40 milligrams, versus placebo, and a follow-up that went for first 12 months as 3 monthly and then 12 monthly. What was the rationale of this study? That we do have all the heart failure pillars, including SGLT2 inhibitors, but there still remains a high unmet need. Mind you, 1/3 of the patients easily come back to the hospital because even with the 4 pillars, they have not been optimized to the doses, or there are reasons for them to come back, triggering factors. So we already know that spironolactone and eplerenone have approved efficacy in HFrEF, but not necessarily in HFpEF, and therefore in HFpEF you don't have them in the current guidelines, as you are aware of. Finance had randomized 6,000 patients after exclusions and about 3,000 to each arm. In the randomization timing relative to the most recent worsening heart failure event, less than 7 days, more than 3 months, and 7 days to 3 months. So you had patient very early and up to 3 months, and then almost close to half or more than 3 months or no prior worsening heart failure. The LVEF in this particular trial had a EF between 50 and 60 and 45% and more than 60 and 19%. So that would mean 2/3 had almost what you can label as a preserved EF, and the remaining 1/3 as HFrEF. This is a very important landmark CV outcome trial. The fine arts had CV death and total heart failure events, the hard endpoints, as primary, and also included improvement in the NYHA scores, class, and the KCCQ TSS quality of life, and of course the composite and renal endpoints, which means a decrease in the eGFR to more than 50. Secondary endpoints was all-cause mortality. All countries were a part of the fine arts study, including India. We did have patients from almost 28 patients from the country. And the average age was 72. Men, women equally represented. Asian population 16%. Almost 70% at class 2 NYHA. LVEF was 53 percentage. Systolic BPs was 130. Anti-proBNP was 1050. I thought there are 2 important aspects on the right side of the chart when you look at demographics of diabetes, AFibs, and hypertension. Pay careful attention that hypertension were 88% of these patients, and that half of them had a eGFR of less than 60. One aspect was the lesser use of SGLT2 inhibitors in this study. And I understand that there is another sub-study that will come up on this. And here is the primary endpoint: CV deaths and total heart failure events. This is just fantastic. 16% relative risk reduction as compared to placebo. P-values less than 0.007. Absolute risk reduction is 3.3 per 100 p-values. And here are the secondary endpoints for total heart failure events, and you can see the 18% relative risk reduction. P-value is significant. The primary endpoints at a glance can be put together: CV death and total HF, or CV death of first HF event. Very, very good results. And it did not matter. All pre-specified subgroups, irrespective of the EF, benefited. You can take age, gender, diabetics, non-diabetics, hypertensives, EF less than 60 or more than 60, all NYHA classes, potassiums, everything, anti-proBNP levels, use or no use of SGLT2 inhibitors also. So irrespective of this, there was an improvement in quality of life, the NYHA class, and the renal composite endpoints. So the renal composite endpoints had small number of events, but no significant difference. Naturally, you would be concerned with MRAs for the hyperkalemia, and they were on the higher side. Potassium more than 5.5, 14.3%, more than 6, 3%. But then investigator reported hyperkalemia led to hospitalization in just 0.5% and not a single mortality, no deaths reported. And systolic blood pressure less than 100 was 18.5% versus 12.5% in placebo. I thought this is a very important study, and therefore I brought it to the highlight that now the fourth pillar of heart failure therapy is strengthened by MRA and finerenone. Also, I believe this may get into the guidelines of how you use finerenone in patients with HFpEF when you just have diuretics and SGLT2 inhibitors as of now. There were also trials on tricuspid regurgitation and right heart failure. Let's just look primarily into this, and rather than getting into the aspects of interventions. This is neglected for a long time. It's considered as a secondary problem, which is really not. TR would have the same symptoms: shortness of breath, reduced exercise capacity, ascites, and pleural effusions, and grossly underestimated. And this TR in HFrEF, mid-range, and HFpEF, here are in the two arms, chronic and acute, and you can see that in the pan-European registries, TR is quite high, and the survival at 5 years after diagnosis of the tricuspid regurgitation just gets down as you go from mild to severe. So that establishes it. The pathophysiology and extra cardiac consequences are well known. You are aware, of course, that if the heart fails, right side heart fails, there's a pulmonic congestion and a tricuspid regurgitation. What it back follows is a visceral congestion, hepatic dysfunction, renal failure, and malabsorption. These are vital. So you look at the affection of the entire cardiorenal metabolic sort of triad: liver, kidneys, and the gut. And as the cardiac output drops, as the right-sided heart failure and TR gets worse, you can have cerebral ischemia and physical decongestioning. Severe TR is linked to both heart failure hospitalizations, worsening of renal function, worsening of hepatic function over a period of time. And therefore, there is the tricuspid valve edge repair available now. Just like MitraClip brought the mitral regurgitations into control with a mechanical approach, so also it can happen with the tricuspid valve too. Not necessarily that one has to do it in patients of left-sided heart failure leading to TR, but tricuspid, primarily because of a right-sided heart failure, has now a therapy. Finally, we have atrial fibrillation and heart failure with preserved ejection fraction. Very tough comorbidity which comes up is obesity. You can see obesity, obstructive sleep apnea, and deconditioning are shared aspects of HFpEF and AFib. So if you look at those comorbidities in clinical real life practice, obesity, sleep apnea, deconditioning, elderly people, coronary artery disease, which is close to half the patients, CKD, and the COPD. We must remember that these comorbidities both trigger or precipitate atrial fibrillation, and in the presence of atrial fibrillation can truly worsen HFpEF, truly worsen HFrEF, which we already knew. And therefore, there are patients of HFpEF who get back into the hospitals with a worsening outcomes when AFib comes in. That's where sacubitril valsartan, MRAs, are going to play a very vital role, specifically sacubitril valsartan. There is a ESA HFA HFpEF score, and I don't really have to read through it, but this is available everywhere in the guidelines as to how you look at diastology at the mitral inflow area, measure the left ventricular mass and the left atrial volume and thickness, just to keep it simple as a suspicion, mind you. When you forget all these tables, if you have a patient who is short of breath, shows clinical signs of cardiac failure, has a high NT-proBNP. When echo is done, has a thick left ventricle, a dilated left atrium, like a pear-shaped, and then a dilated left atrium and a mitral regurgitation, despite the normal LVEF. This is the sort of phenotype where HFpEF should be strongly suspected. This is a good clinical clue. There are, of course, other phenotypes, and this is just one pointer. What drugs will help AFib and HFpEF? All these drugs, right? You have everything that here can benefit. But I must say for sure that the role of MRAs now are going to get better. We don't have really a great evidence with SGLT2 inhibitors on atrial arrhythmias versus ventricular arrhythmias, right? ARBs, ARBs, ACE inhibitors have helped, and ablation has, of course, certainly helped. So it's important to look at heart failure and AFib. What has to be done along with the guideline-directed medical therapy is try and get both a rate control for the chronic cases as well as try and get a sinus rhythm back in patients where it is feasible or more acute. Very important is that these patients require a NOAC, and the dabigatran and rivaroxaban, apixaban have a great role to play in terms of reduction of stroke. Thank you very much for the patient hearing.
Thank you so much, Dr. Jadhav, sir, for your wonderful presentation. Now we will move to Q&A session. We have a couple of interesting questions from the audience, and I'll read out one after the other. So the first question is from Dr. Prathamesh. He asks, sir, what is the differential placement of rivaroxaban versus apixaban versus dabigatran in clinical practice? Your clinical take on the same. Dr. Ray, would you like to go first?
Yeah, it was in my talk. They are almost equivalent. It's your personal choice, but there are certain subtle differences as well. It has been shown that apixaban actually has got an edge over rivaroxaban and dabigatran in terms of total mortality reduction, which was not shown by the other two compared to warfarin, of course. Secondly, the net clinical benefit, that is thrombosis versus bleeding, this is positively in favor of apixaban compared to dabigatran or rivaroxaban. Dabigatran 150 is clearly superior to warfarin in terms of thrombosis, causes much more hemorrhage. Whereas dabigatran 110 is non-inferior to warfarin in terms of thrombosis and also non-inferior to warfarin in terms of hemorrhage. So basically, it's just a substitute, not much of benefit. Rivaroxaban is almost equivalent to warfarin in terms of thromboembolism prevention, not much of advantage, but causes more bleeding, particularly GI bleed. So why do we give it? Because of ease of administration, no monitoring, no food interaction, no drug interaction, etc. But apixaban is the only one which showed benefit over warfarin in terms of thromboembolism prevention, in terms of hemorrhage, less hemorrhage, and in terms of total mortality. So I think, but the only problem with apixaban is compared to rivaroxaban, it's a BD dosing, and the dosing is a bit complicated. And that is why I also mentioned in my lecture that apixaban is the most vulnerable molecule to get a wrong dosing, because this 2.5 BD is very commonly used, and it has been shown that 80-90% cases it is wrongly used at an underdose. You have to have very clear definition of age above 80, weight below 60, creatinine above 1.5, any two of the three, not only one. So any two of the three, if present, then only your dose is 2.5 BD. In all other cases, it's 5 BD. But in our day-to-day practice, we see that most physicians get a bit scared and give a lower dose of Apixaban, which is not only not useful, it's actually harmful. So that is the problem with Apixaban. But if you ask me, Apixaban is my preferred molecule. But if the chance of thrombosis is very high, patient is full of thrombus, then perhaps Navigator 150 BD has got an edge. But rivaroxaban is neither this way nor that way.
Thank you, sir. Dr. Uday Jadhav, sir, your comments.
I completely endorse Dr. Soumitra comments. I mean, he has explained it thoroughly. Absolutely. There are no additional comments. It's all very well said.
Thank you, sir.
Questions?
Yeah. Sir, so second question is from Dr. Brijesh. He asks, sir, is universal screening of LP little a for all adult patients a good option? Universal screening of LP little a. Your take on the same.
Make a quick comment and then Soumitra can add, of course. You know what? Liposmall, as they say, is now getting the importance for two reasons. One is the UK Biobank showing what are the levels of lipoprotein A that are correlated with cardiovascular risk. And second is that there are 2 or 3 medicines now which will be targeted against liposmall A. In the US, we have Olpasiran, Pelcarsen, which is coming up, and there are a couple of others. The only problem is we do not know what are the exact figures or what is the cutoff margins to confer risk for the Asian Indian ethnicity. Now, this may differ unlike the Western literature and data, but here is one of the recent proposals that the Lipo A, if it is more than 30, along with the family history, and if the LDLC levels are high, then the cardiovascular risk is greatly elevated. We don't have it in the guidelines. We cannot be absolutely sure. It's going to take a little while, even for epidemiology data from this country. But if you are asking me, is it something worthwhile doing? 100%. It's the only test that confers or tells you about the genetic risk for each ethnicity, including Indians who have so much premature coronary artery disease. So we should all measure our lipo-As. The American College of Cardiology meeting last 2 years has a booth where every cardiologist can check it free for himself or herself. And believe me, it's one of the most visited one in the entire ACC. I've done it myself, so I can tell you that, right? So I think it's extremely important. Dr. Soumitra's comment, and we can go quickly to the other questions.
Yeah, you have done everything. I just want to mention that it has been given in all guidelines that do it once in your lifetime. I think that doesn't make any sense to anybody. What is this doing in your lifetime? I mean, it is just a certificate before your death with your death certificate that I have got an LPA done just yesterday. It doesn't make any sense. It shows. So I tried to push. I was part of the Asia Pacific lipid guideline committee. I tried to push it. Do it in the first lipid profile done in your lifetime. Maybe at the age of 18, 20, 25, whenever. You do the first lipid profile, include the LPA. Then only you can have an objective assessment. Where do I stand? And when the medicines will come, as Dr. Jadhav said, the things will be standardized. But we need to know and spread the knowledge. That is the only thing I want to add. Do it universally and not just any time, but on your first sample of lipid when you are doing in your life. That is my mission.
Thank you, sir. Next question is from Dr. Siddharth, who asks, in patients without coronary artery disease, which will be the better option for lipid LDLC control? Initiating high intensity statin versus moderate intensity statin plus ezetimibe. So over to you, Dr. Uday Jadhav, sir.
You said that is in primary prevention?
So yes, sir, without coronary artery disease, so primary.
Well, everything goes by the risk assessment, right? So once you have assessment of the subclinical atherosclerosis risk, a risk is a risk. It doesn't matter whether it's subclinical or clinical. And then once it is established, this patient goes for a moderate or a high intensity statin. The question is it good to add ezetimibe instead for primary prevention? I mean, eventually the LDL-C levels matter. And therefore, adding ezetimibe may not be a disadvantage. But here is the point. Statins have been proved beyond doubt in primary prevention, both with a moderate and high intensity. Please do that. For some reason, if you want to add on ezetimibe to lower the dose of statins, one can do it. But mind you, the ezetimibe clinical studies have been more in patients who have disease and in secondary outcomes. Statins from the WASCOPs and the early Texas studies in 1997 onwards have been in primary prevention. So I would still, for primary prevention, be a little more inclined towards giving statins rather than a combination. That's the answer.
Dr. Ray, sir, any comment from your end?
This question has got two aspects. One, you're saying that the coronaries is normal. It doesn't make any difference. I mean, if you see the ESC guideline 2019, who are the highest risk people? Number one is atherosclerotic vascular disease. Number two is advanced CKD. Number three is family hypercholesterolemia. Number four, diabetes with target organ damage. So coronary artery disease is not an essential pre-criteria for bring you to the highest risk group. There are a lot of other criteria without coronary disease. Number two, coronary artery disease is not the monopoly of atherosclerotic cardiovascular disease. You can have an absolutely normal coronary with your carotid plaque, with your femoral artery plaque, with your mesenteric plaque, which are equally important as a coronary artery disease. Thirdly, when you say coronary arteries are normal, how do you say that? Doing a coronary angiogram? It doesn't make any sense. Also do an IVA study or a CT angiogram. You do not know what is the atherosclerotic plaque burden, what is the calcium score. So again, even the loosely saying coronary artery disease doesn't make any sense. So coronary artery disease is just one criteria to put the patient in the highest risk when your LDL target is below 55. There are loads of other things without coronary artery disease which will make you a deserving candidate for LDL below 55. Now, once your LDL target is below 55, whether you give high intensity statin only or moderate intensity statin with ezetimibe is a bit controversial. Nowadays, there are certain certain groups coming up saying that it's better to do moderate statin with ezetimibe, which will do the equal job for LDL cholesterol, but will less chance of side effect like a new onset diabetes or muscle. But as Dr. Jadhav very rightly said, the proof of pudding is in testing. So whether just by reducing LDL cholesterol, by that means whether you translate it into equal clinical events as with a high dose of statin, we really do not know. But this is an agreeable and attention-seeking proposal coming up. We need to wait for more evidence.
Thank you so much, sir. So next question is from Dr. Deepa. Her question is, 2024 ESC guideline has introduced the term elevated BP and has brought a new normal of 120 by 70 mmHg. How relevant is this for Indian population? Dr. Reza?
Yeah, we did not discuss it, and I said carefully we avoided the clinical guideline. And I must say whether Uday will agree with me, I was a bit disappointed with the new hypertension blood pressure guideline of ESC. I found it's a step back from the European Society of Hypertension guideline which came last year. It's rather a bit retrogressive. And actually these 120 to 140, they are saying high normal BP. And then 140 up is hypertension. It's just a toying with your nomenclature, you know. It was a pre-hypertension, grade 1 hypertension, mild hypertension. You are talking these things for last 30 years without really making any difference to anybody. And very funnily, you are saying 120 to 140 is your high blood pressure, keep an eye, blah, blah, blah. And then once with lifestyle, it is not controlled, you treat to keep it between 120 and 130. And you are saying 130 to 130, 120 to 130 is high normal, which is not very right. And when your target is 120 to 130. So you are keeping your blood pressure deliberately to high normal rather than normal. So it's almost, you are talking the two things at the same breath. So I need to go through it more thoroughly. So what they're actually up to. Whether they are themselves confused, they are confused, because there was a question answer session after that. I attended also on live on that online, and the guideliners could not answer most of the questions. And they said, being guideliner, I now know that it's very difficult to change things. That was the answer. And when the people asked, what is your relation or anti-relation with European Society of Hypertension, they said, we have no relation. They're a separate body. Their guidelines are different. So I found that thing bit not at par with the ESC philosophy. What is your idea, Uday?
Yeah, Soumitra, well said. I agree. So first comment is that I would simply want a normal blood pressure and a hypertension. I don't want too many subcategories.
Absolutely.
Because that's really putting everything into a dilemma as to how you're going to approach it. One, two, is that, in the next 2 years, we are going to be very busy reading a lot of articles on what are you going to do with the high normal and what are we going to tell our patients for this high normal.
Absolutely.
It really doesn't matter whether it's from normal to hypertensive in terms of the dietary salt restriction. That's applicable for high normal also. Exercise is also applicable. Alcohol reduction is also applicable. Tobacco reduction is applicable. So what is it new that we are going to do? Why should we create a new category? Because then you will start saying, do we need a clinical trial for this? Do we need to, I think this is just a continuum. And we do not know how long a patient will stay in that high normal. We don't have a linear relationship graph being established to say, here are normals, here is a hypertensive, and this is how long is going to take, right? So I think let's not have such sort of new categories that just adds to our own confusion, unnecessarily panic the population and community. They have too many things to panic about now. This is one more add-on. And I don't know what drug therapy, if at all, can be offered. Not that they are saying you offer a drug therapy, but frankly, I don't think this is all required. So
I was a bit disappointed with that, honestly. I didn't expect this from them. Anyway, but we have to read more. Perhaps there will be some clarification, some supplement we do not know as yet. Maybe.
Any questions before we close? New questions?
Yes, sir. So we have the last question from Dr. Vivek. He asked about the management of atrial fibrillation in HFrEF patients. Your clinical pulse. Management of atrial fibrillation in HFrEF patients.
Right. So, like for everything, you treat the etiology of HFrEF. That's very important. You see, if you treat the etiology, HFrEF will go away. Probably the atrial fibrillation also will go away in quite a number of patients, or it will be better to control the rate, even if the rhythm doesn't get controlled. So that's the first thing. Treat the cause and treat the HFrEF. Atrial fibrillation remains as a treatable target once all the other drugs are established. Right now, what do you have in hand then? Either you slow down the rate, which is proper thing to do if the rhythm is not going to get controlled, or we can control the rhythm with the conventional antiarrhythmics which are given for treating of atrial fibrillation. That's on. And fourth, which we already discussed just a while ago, bad anticoagulant for sure. And even in this patient, aspirin or no aspirin, the NOACs are on board. So one of the NOACs should be added. So that's the brief answer to this poll.
Dr. Reza, thank you, sir. Dr. Reza, anything?
It's basically bad news. It's a very bad combination. Perhaps the worst possible combination on a heart failure patient to have an AF on board, because whatever little cardiac output you are having, you are losing that with the atrial kick is gone. And even the beta blocker, the drug of choice for HFrEF, has been shown that loses its efficacy when atrial fibrillation sets in a HFrEF patient. So this is bad news. And also thirdly, only last year it has been shown that even in a very terminal heart failure case with atrial fibrillation, still if you go for ablation of atrial fibrillation, you can offer some hope to these desperate people who really are written off from any quality of life. So perhaps you can think of a drastic measure like atrial fibrillation, ablation in case of a HEP patient. But overall, this is a very poor group of people and they don't live long. That is my thing.
Thank you so much, sir, and for your wonderful insights. I now hand over to Dr. Parthasarathy, sir, for his final vote of thanks.
Thank you, Dr. Prajapati. I must say it was an academic feast on Teachers' Day, and it's always an honor to hear some of our topmost teachers, Professor Ray as well as Professor Jadhav. The level of knowledge, the knowledge sharing, the unfiltered discussions, which ultimately give key points to clinical practice, I'm sure have been very engaging for the audience, because we have had consistent 1,500 plus logins for this meeting, and it's kudos to the prowess of our teachers.
I can't hear, doctor.
Sir,
I can't hear you for some reason.
Okay.
Dr. Partha,
So I just said, sir, I said it was an honor to host you. It was an academic feast that the audience had. Am I audible, dear sirs?
I can't hear you, doctor.
Yes, sir, you're audible.
1,500 delegates consistently logged in.
Yeah. Thank you, sir. Thank you, sir. Thank you, sir. Yeah, 1,500 delegates who have been consistent. Very engaging session as far as Q&A is concerned. And as I said, very unfiltered discussions on what is actually relevant to the Indian practice, not just a road discussion of trials. So hugely appreciated. We dedicate this to both our teachers, Professor Jadhav as well as Professor Reza.
Thank you. Bol raha hai.
Our pleasure.
And we also thank you, dear audience, for actually taking this time of yours to join in for this. And we are very sure that the takeaways from this session would actually empower you in your clinical practice and ultimately improve patient care outcomes. So thank you, one and all. Good day and good night. And last but not the least,
Dr. Prajapati and Docomo, you are the first one perhaps to do at least for me, it was the first. Is lined up lots of programs by national and international giant players, but you are the first to hit the ESC to bring to the audience. I think that's why the audience is still very, very hot to know about the ESC, what has happened. So thanks that you brought it so quickly after it was finished on Monday. Okay.
Thank you, sir. In fact, the audience has deeply appreciated the session. Thank you so much, dear sirs. Thank you. Wishing you all a great day. Good day.
Thank you, I also. Nice to meet you after some time.
Thank you, sir.
Thank you.